O professor Scott Collier é professor associado em Ciências do Desporto e Exercício na Universidade do Estado de Appalachian. Os seus interesses de pesquisa centram-se no efeito diferenciado do exercício aeróbico e anaeróbico no sistema cardiovascular, assim como no sistema nervoso autónomo. Atualmente, os seus projetos de investigação baseiam-se nas diferenças entre sexos relativamente à condição pré-hipertensiva e à hipertensão.
Boa tarde. It's the only thing I know. Okay. So first up, I want to thank the organizers of this committee. They've done a great job in the hospitality that they've extended to us. I feel at home, I guess already in Portugal. It's quite a bit like where I'm from. Dr. Utter and I are from Boone, North Carolina, and that's kind of what it looks like. It looks like this all the time. Well, a few objectives, I guess, what we want to talk about. Some of it's just the clinical relevance of exercise. I want to turn it to, instead of just the strength training, there is a clinical relevance. And how we measure these cardiovascular adaptations, even with resistance training, with strength training. And then the health implications of resistance training. Even just a few years ago, resistance training is not recommended. As far as the guidelines go, American College of Sports Medicine, American AHA, they all say aerobic training. So then we'll talk about some of the mode similarities of exercise training. And the first implication with resistance training and why they think resistance training, we probably don't recommend this, is because hypertension, individuals with high blood pressure, 55 million just in the US. So a lot of people have high blood pressure. So, and the problem, I guess, is that with high blood pressure, we don't want resistance training. It wasn't recommended. And now with pre-hypertension, so now we have a new, the JNC7 actually is a new classification of pre-hypertension, which means you're getting towards hypertension or high blood pressure. So 120 millimeters of mercury systolic, 80 millimeters of mercury diastolic, that would put you in a category of pre-hypertension, moving towards hypertension. So if it's untreated, if we don't do anything with this, it's a precursor for stage 1 essential hypertension. We're moving towards it. It's also associated with excess morbidity and deaths from cardiovascular causes. So what are the treatments? We have drugs, and we're going to talk about that real quick. As far as that's what most people do. So in the States, most people just take drugs. They don't exercise. They just take drugs for this. We have psychotherapy, and that works a little bit. It works better if it's combined with exercise. And then exercise is kind of what our focus is going to be in this talk. So as far as drugs go, there was a big study a little while back called the Trophy Study, the Trial Preventing Hypertension. So it was a 4-year trial, multi-center, randomized study, untreated pre-hypertensive. So these are people moving towards hypertension. They wanted to look at the effectiveness of drugs. So a great design, 722 subjects, 30 to 65 years of age. They used candesartan, which is an ACE inhibitor, and then they used placebos for the other group. 2 years dosing with this ARB, and then a 2-year follow-up. They dosed them for 2 years, they stopped, and then they followed them for 2 more years. So 4-year study, big study. This is what happened. So the people that were on the placebo, their blood pressure, if we look at percentage, number of patients without hypertension, we started out here. So at the 2nd year, we saw that people on candesartan on the drugs only elevated a little bit as far as cumulative insulin incidence. The people on placebo quite a bit. But if you look at 4 years, the reduction is less than at the 2nd year. So on the drugs work pretty good. Off the drugs don't work so good. So they said, this is Steve O'Julius's group, pharmacologic treatment of prehypertension may prevent or postpone the development of hypertension, so we can stop it in prehypertension. But they only showed a 26% reduction of new onset in the drug group versus the placebo at the end of 4 years. Well, the problem is, so just in the US, that's 25 million people go on drugs, right? These drugs have a lot of side effects. So that's a big economic impact because insurance would buy these drugs. And then there were a lot of skeptical results. There were a lot of comments, I guess, to the editor of this saying, we didn't really like your study, the way you did the statistics and stuff. So then if we look at aging and antihypertensives, the problem is as we increase in age, right? As we get older, there's irreversible damage to the vasculature because of the hypertrophy that happens to the smooth muscle or atherosclerosis to the vessels. So that diminishes the long-term responsiveness to temporary antihypertensives. And now we're starting these people at a younger age. So as we stay on these drugs, it's not so good. The other thing is we have an increasing incidence of hypertension, right, which leads to cardiovascular disease, the biggest disease worldwide. So directly related to changes in lifestyle and diet, which we've talked about a lot so far in this conference. But earlier onset than a drug therapy doesn't solve the problem if obesity and lifestyle changes or sedentary lifestyle choices keep increasing, right? So we get to exercise, and we all know exercise is good for the cardiovascular system. It's good for the skeletal muscle system. We know that low cardiorespiratory fitness is a strong and independent predictor of cardiovascular disease and all-cause mortality. Higher activity levels, higher cardiovascular fitness, lower blood pressures. So exercise can be an antihypertensive lifestyle to help prevent and control blood pressure. We know it reduces risk factors. So there's been some meta-analyses. This one was done by Taylor a long time ago. He looked at contemporary medications and interventions there. So this is cardiac rehab. Estimated reduction in mortality 20 to 32%. So decrease in death 20 to 32% with exercise. And exercise is associated with about a 30% benefit in terms of cardiac risk. So that means really similar to lipid lowering in these antihypertensive interventions. 30%, and they saw 26% with the prehypertensive drug therapy. So actually it's a little bit better in these studies. Exercise is better than drugs. So the mechanism then, how exercise can be better, is probably has to do with this vascular wall conferring a vascular conditioning effect. So exercise helps the vessels. The vessels help take the pressure or take the workload off the heart. The vessels feed the muscle, so increased blood flow is probably the mechanism then for exercise to help decrease this risk. So if we look at aerobic exercise training only, and this is what's recommended by most of the governing bodies, aerobic exercise training at a moderate intensity, about 65% max VO2. It's been shown to decrease resting blood pressure of individuals with hypertension, so already diseased. We look at 8 to 17% systolic blood pressure decrease, and a 6 to 13% diastolic blood pressure decrease. So in this, basically, the 8 to 6 is with training. The 17 to 13, the higher end, is usually an acute bout. So this is afterwards, after one bout of training, usually a little bit higher. The problem, people want to strength train, right? And that's a little bit about what you guys are doing today. So people want to look like this, and they're already looking like this. So the way to go is strength training. But right now, we don't say, right now the governing bodies don't use strength training as a modality. They don't recommend it. There's only been 11 studies that have looked at blood pressure responses to resistance training. There's 11 studies published with about 174 in the exercise group and about 135 in the control group. This is in adults. And they've seen a mean resting blood pressure, 4.6 reduction in systolic, 3.8 in diastolic. So they've decreased it with just resistance training. And these are pretty similar then to the low end of aerobic exercise. So it looks good. So resistance training is only recommended as a complement. They're still saying do aerobic exercise, don't do resistance training. This was 2005 in the American Heart Association to an aerobic-based exercise program. More people want to take part in resistance training because it's faster. You can get through a resistance training bout in about 30 minutes. We'll use the machines. It increases bone mineral density if it's weight-bearing, right? And there and fewer contraindications, fewer problems, because you can sit down if you use machines. You can do other exercises if you had some biomechanical problems. If you have ankle problems, you can't run, but you could lift weights. So if we look at motor training, resistance training then leads to decreases in blood pressure, yet all the data show increases in heart rate and increases in arterial stiffness. And we're going to get into a little bit of arterial stiffness. And And it's probably because right now they thought, well, this is a vessel. This is a blood vessel. This is a kind of a cool picture. We look at permeability of the blood vessel. And the single cell layer on the inside is called the endothelium. So in here, the single cell layer of the vessel, that's actually where we get the dilation, the bigger, or the constriction, the smaller, which controls blood pressure. Dilation that we just talked about is done here. So as blood flows through that vessel, it actually pulls on this endothelium. This is a single cell layer. When it does that, we see calcium drop in. We see then arginine convert to citrulline, but actually a byproduct, this nitric oxide, goes into the smooth muscle, so what surrounds that vessel. And it actually blocks with this calcium. It can't contract. So therefore, it relaxes. It gets bigger, more blood flow. So that's good for the muscle. Probably one of the bigger differences, if we look, a small change in radius. So if we look at this, a 1 millimeter change in radius, maybe going from 1 to 2, we see a huge change, 16-fold change then in flow. A lot of blood flow with a small change in the size of that vessel, a small change in the radius. So if we look at the endothelium, this is what it looks like in a micrograph. Diseased, not good. Healthy endothelium, this is good. You can even tell which way the blood flows in here. So this is actually the health of the vessel. In some countries, Republic of Georgia, they always say you're as old as your vessels. So you want your endothelium to look like this, not this. This is training. This is sedentary. All right, this looks like it's going to work. So if we look at how do we measure this stuff, what we call arterial stiffness, the elastic of that vessel. So if we look at this, we gate this to heart rate at the top. And then when the heart beats, this is a blood that comes out of there. This is the wall that actually expands. So the wall cushions that blood, that bolus of blood that comes out of the heart. And when it does that, it decreases blood pressure. The heart doesn't have to work as hard. That's good. This is exercise training, gives us elastic vessels. If we look at a stiff artery, if the wall doesn't contract, there's more resistance. Blood flow is faster, blood pressure higher. So if the wall doesn't contract, it goes through a lot faster, therefore higher blood pressures. So we measure this with a technique called pulse wave velocity. So here we look at peripheral pulse wave velocity. We can do central and peripheral. Central would be here in the trunk. Peripheral would be from this femoral down to dorsalis pedis, probably, down here in the ankle. And what we're going to do is we put a tonometer, something to measure that pulse wave. Here we measure it at the carotid. We get the wave, arterial waveform. So we look at the arrival of that pulse wave. And then we take it down here at the ankle. We find out the arrival of that pulse wave. It's very simple. So then it's when this one arose versus when this one arrives. So we get the change in time between the two. And that gives us pulse wave velocity. So it's just distance over time, how fast it goes. So if it's healthier vessels, it travels slower. If it's diseased vessels, it travels faster. So one of the studies that we did, this is the first study actually that took prehypertensives. We had 20 men, 10 women, so 30 prehypertensives. At that time, this was the largest study in prehypertension. No meds. They couldn't be on any meds because even aspirin changes your endothelial function, changes the vessels. We gave them a lab familiarization because we're looking at blood pressure. And then we took 4 weeks. We randomized them into either just resistance training or just aerobic training, 2 different groups. We measure their VO2 peak and then their 10 RM. So the first visit, we gave them 15 minutes of supine rest. We did that pulse wave velocity that I just showed you. We measured beat-to-beat blood pressure, and then blood flow with reactive hyperemia, so peak blood flow. The exercise training, you'll say, no Zumba. We did treadmill, 65% VO2 max, and that's how we get that for that heart rate. 30 minutes, 3 days a week. That's what they did for aerobic training. Resistance training, 3 sets with a minute rest in between. And then we used machines. We used Life Fitness machines. Leg press, lat pull down, leg extension. So we did upper body, lower body, and we moved this way. What we did try and match was the time spent, so training volume, time spent in aerobic, and the time spent in resistance. We probably should have talked to Dr. Scott a little bit more about this, trying to match these two. But so here's our subjects. In the aerobic versus resistance, no significant differences in the descriptive characteristics, no difference. At the end of the training, so in 4 weeks, we did this in 4 weeks. 4 weeks of training, systolic blood pressure with the aerobic group decreased about 5 millimeters of mercury. If we look in the resistance, about the same, about 4 millimeters of mercury decrease in blood pressure. This is resistance training only. If we look at diastolic, about the same changes, so mean arterial pressure then, the product of about the same changes. But heart rate, this was the difference. A decrease with aerobic training, an increase with resistance training. So an increase in heart rate means we should see higher blood pressures, but we didn't. We saw about the same decrease, yet resting heart rate went up. And that's usually what happens with resistance training. We get an increase in resting heart rate. So then we go back and we look at pulse wave velocity, that I just showed you. So we looked at central, so from carotid down to femoral. These are elastic vessels. We see with aerobic training a decrease in central pulse wave velocity. That's a good thing, right? We get more elastic vessels. With resistance training, we saw an increase, so divergent results, not so good. This means stiffer arteries, higher pressure. Peripheral pulse wave velocity, same thing. Decrease with aerobic, increase with resistance training. So the first question we got was this arterial remodeling. Did the arteries remodel? Did they change? Well, we showed it in 2006 that even with an acute bout, we see these changes. So it can't be that they remodel. So we see with resistance training, it went up as far as the extensibility, the elastic, the stretch of the vessel, and with aerobic training, it went down. So it has to be what we call functional remodeling. Then we looked at heart rate variability, so how the brain programs that heart to make these changes. So basically central command. And we saw not a lot of difference between pre and post with aerobic. And if we move down, we see this ratio, LF to HF, which means sympathetic. That's like the gas pedal on a car, drives heart rate up. So if we look at that, this ratio, we look at it decreases in the aerobic group. Heart rate went down. That makes sense. It went up in the resistance group. Heart rate went up in the resistance group. So that makes sense. But none of these other functions except for HF, which is a parasympathetic, that decreases heart rate. We see parasympathetic went up, so that means heart rate went down. And over here we see it went up, 654 to 11. It went up even more here, but so it goes up a little bit in the aerobic, but we look at the ratio, this makes sense. Overall, this goes down, this goes up, very small, but we only saw a small change in heart rate. Baroreflex sensitivity. So this actually governs. This is the part in your body that actually tells the vessels to relax, get bigger, or constrict, get smaller. And the baroreflex, with resistance training, the sensitivity, the ability to detect these changes and change goes down. Sensitivity decreases. That's not good. With aerobic training, sensitivity increases. That's good. Now, this is where resistance training starts getting better. So we see forearm blood flow results. So we use Hokinson machine, which is mercury inelastic. I don't know if you guys are familiar with that. So we don't have to go inside the body. We can actually measure it on the outside, blood flow. And we saw with aerobic training, blood flow goes up. Pre to post, significantly from pre to post, we see a change in. With aerobic, we see a small change with resistance training, and it is significant. It goes up a little bit. This is just resting blood flow. So the capacity then of the arteries gets better with resistance training and with aerobic training. So the good news then for resistance training, post-ischemic, so what we call reactive hyperemia, we put a blood pressure cuff on the upper arm. We pump it up so no blood can flow through there. So downstream, so below that cuff, everything starts to expand, but there's no blood flow coming through. Above that cuff, there's a whole bunch of blood that just sits there. So what happens is we release the cuff. And then with the arteries, we basically look at the slide a few ago that shows the stress on that wall that stretches the endothelium signals for this vasodilation. So we have what we call endothelial dependent. We have to have that endothelium intact. We see a huge increase with resistance training, a bigger increase than with aerobic training. So with this shear stress, with this high level of blood flow going through there, the arteries become better. They can handle more blood flow. That's good because with resistance training, we tend to see increase in skeletal muscle mass. Now we have the arteries that can deliver the blood flow to the skeletal muscle mass. Post-ischemic area under the curve, so this is the total amount of blood in 3 minutes, basically. After the cuff was released, we measure it for 3 minutes, a lot higher with resistance training than with aerobic training. These were sedentary people, and all of a sudden we see these big changes. So the carrying capacity then of the vessel increases. So the conclusions from that, pretty similar reductions in resting blood pressure between resistance and aerobic training. So 4 weeks of moderate intensity resistance training increased arterial stiffness, but aerobic training decreased arterial stiffness. So that's probably why American Heart Association and the World Health Organization, they didn't recommend resistance training. But there were significant increases in peak and area under the curve forearm blood flow in response to that reactive hyperemia, putting the cuff on. So that's an increased vasodilatory capacity. The vessel was bigger with resistance training, but only in the resistance trained group. So training-induced changes in the stiffness appear to be unrelated to changes in blood pressure, because they both lost the same, and vasodilatory capacity and body weight. So when we put those into the regression, they didn't contribute. So one of the things we noticed, a lot of people are starting to put out Tanaka's lab, Miyachi's lab. They started putting out that resistance training is bad for your vessels. It causes stiffness. Aerobic training, good for your vessels, decreases blood pressure more than resistance training. But then there started to be some papers that showed resistance training didn't increase your stiffness in your vessels. So the funny thing is, the people that did this were Kobichuk and Casey. They did it in postmenopausal women. So we set out then to look at the difference between men and women, so sex differences in these two. So we had the same design, but the thing is with women, the 6th decade of life, after menopause, they catch and surpass men in hypertension, and they don't live as long. So men live with it from when they're about 30. Women start when they're about 60, and they catch and surpass them within 10 years. So 34 to 40% of women 55 to 65 with cardiovascular disease also reported disability. They feel more disabled. With resistance training alone, this goes down to less than 10%. So if you get them on a resistance training program, quality of life increases. So with sex differences that were reported, hypertension now is more prevalent and less well controlled and more severe in elderly women than in men. And we think the differences are probably related to this pulse wave velocity. And that develops greater systolic blood pressure and diastolic blood pressure. So the problem is right now we don't have very good drugs for women. They're better, they're more effective, they have less side effects in men than in women. Exercise is good for both, right? So this one, in FACIT, we showed 4 weeks aerobic exercise and resistance exercise on resting hemodynamics in 34 age match stage 1, or pre-hypertensives and stage 1 essential hypertensives. Here's our blood pressure results. Systolic blood pressure, aerobic, pre and post. Resistance, this is the males in red. This is females in yellow. So we look at aerobic training, pre-136, about 5 millimeters of mercury they lost. Women, about 4 millimeters of mercury decrease. Very close. Resistance training, about the same results. These about 4 millimeters, about 6 millimeters with women in resistance training. So that's probably the greatest benefit, resistance training in women and systolic blood pressure. But if we look at diastolic, men, aerobic training, they lost about 4 millimeters of mercury. Women, aerobic training, about 3. So pretty close. But if we look at diastolic, men, only a couple millimeters of mercury diastolic, 4 weeks, aerobic training. If we look at women, they lost 10 millimeters of mercury in diastolic blood pressure with the resistance training. This is comparing two groups at the same time. So we look at aerobic and resistance. Most of the studies, in fact, up till now, I haven't seen any that compare both at the same time. All these studies, they only compare, they go out and they only look at aerobic training, or they only look at resistance training. So this is both at the same time. So in the same season, winter, summer, spring, same time, same equipment, same technicians. So that's probably the most important when we start comparing resistance and aerobic training. Pulse wave velocity. So this was kind of our hypothesis, and this was the difference. We see pulse wave velocity. We look at increases only in males, no change in females. So pulse wave velocity only increases in males with resistance training, doesn't change with women. So this is good. Both modes reduced resting blood pressure, but resistance exercise increased pulse wave velocity in men, no difference in women. So this is probably a lot better for, instead of drug therapy, for women. So it shows both sexes benefit from blood pressure lowering effects of resistance exercise, but women that have hypertension or pre-hypertension have an added advantage compared to men, that it doesn't increase arterial stiffness. So further than that, if we look at the mechanisms then, so this makes it better for women because women are also at risk for osteoporosis, right? And with strength training, we decrease that risk. So what are the mechanisms then? We look at variations in this oscillatory pattern of blood flow in limbs during exercise, which means we saw the pulse wave velocity. When blood's ejected from the heart, one pulse goes by, then and after the next heartbeat, another pulse goes by. So these are oscillations, one following the next. So Dick Thiessen's lab and Tinkin's lab both showed that nitric oxide dilator activity is directly related to the ratio of antegrade and retrograde flow. So antegrade flow is flowing forward like it should. So this is an ultrasound of antegrade flow. This is what it should look like. When the heart beats, we get forward flow. Retrograde flow, so is moving backwards. This isn't good. So retrograde flow is usually what we see with resistance exercise. With muscle contraction, forces that blood flow backward, actually. So we see more retrograde flow with resistance exercise. We see more antegrade flow with aerobic exercise. So this moving backwards and moving forwards, that's not good, but that probably contributes to increased arterial stiffness. Women, when they contract the muscle, they don't cut off blood flow. We still see blood flow going through the muscle. Men have enough force, enough muscle mass to stop the blood flow, to constrict that enough that it occludes blood flow, it stops it. That's what contributes then to retrograde flow. So that probably explains why men get increased arterial stiffness with resistance exercise than women. So resistance exercise leads to vessel occlusion. It reduces the ratio then in favor of retrograde flow, which takes away that nitric oxide effect. Nitric oxide causes the vessel to expand, vasodilate. So the reduction in nitric oxide dilator activity is proportional to the degree of occlusion. So even at 25 millimeters, if you put a cuff on and increase to 25 millimeters, you get some decrease in this availability of nitric oxide. So a little bit in women, but a lot in men, because men can occlude that, especially in the quadriceps, where there's greater muscle mass. So there's been some studies. We look at ipsilateral. So in baseball, pitchers only use one arm. You look at the opposite arm's not affected. It's only the arm where we do the exercise that's affected. So systemic, we don't see systemic changes. We only see local changes. It's a bladed resistance exercise-induced effect if you do any cardiovascular training. So this is for the people that just do resistance training. If we do any kind of cardiovascular training, they've even shown as little as 20 minutes. On the days opposite of when you resistance train, we take out this increase in arterial stiffness. So it doesn't last. So now we look at inflammation. We know inflammation's greater from resistance exercise. It's part of that healing process, right, and rebuilding process. Inflammation's good to a point. We see more inflammation with resistance exercise than aerobic. So greater exercise intensities extend the influence of localized inflammation in the arteries of the trained limbs. This is just coming out actually right now with Womack's lab. So inflammation's probably one of the contributors then to this arterial stiffness. Thank you.
Thank you, Dr. Scott. O professor Scott, na sua comunicação, abordou então as possíveis estratégias terapêuticas no tratamento da pré-hipertensão e hipertensão. Abordou também as limitações do uso de medicamentos e das psicoterapias. Apresentou resultados que analisaram os efeitos benéficos do treino da força na pressão arterial e na rigidez ou elasticidade das paredes das artérias, embora esta, como ele bem demonstrou, seja uma área de pesquisa com poucos estudos e poucos elementos amostrais. Também comparou o efeito diferenciador do treino aeróbio e anaeróbio em diferentes parâmetros associados à velocidade do fluxo sanguíneo e à regeneração do endotélio das artérias. Perante isto, passaria então à sessão de perguntas. Queiram colocar?
Primeiramente, queria parabenizar a apresentação do professor e a questão que eu tenho é bem simples. É só de saber do professor se ele já tem algum dado com a restrição de fluxo sanguíneo em hipertenso. Se ele já tem um método de treinamento.
So is he asking if when you become hypertensive, do you have reduced flow?
Using the Catson procedure.
Using which one? Reactively?
O garrote.
Oh, Katsu training.
Katsu.
Oh, yeah. So that's Katsu is restriction in blood flow, and you only use a small amount of effort, so 20% of your max, and you train that way, you get about 90% of the strength gain. Okay? So there's not a lot of data on that as far as arterial stiffness. There was one paper that showed with this Katsu method, Japanese method, and they actually just paid American College of Sports Medicine. They gave this honorarium for people to do studies in this. There's been one study that showed worse vessel function with Katsu training. So it's not good for the vessels. It may be good for the muscles, but maybe not so good for the vessels. Why?
Yeah.
I don't know. I haven't seen. There's not a lot of data on that. Why it's not so good, but it has to do with that occlusion time. There's a lot of time spent with that occlusion in an active muscle. So there's a lot of downstream effects of different bloodborne. So there's more inflammation, and that's one of the last slides we talk about, an increase in inflammation, not so good in the vessel. So we see that with sedentary. So it starts looking like a sedentary vessel with the occlusion in training. It probably is from an increase in the interleukins, IL-6, 8, and 10, is what one of the papers had shown. So more inflammation. It appears it doesn't hurt the vessel. It doesn't make the vessel less strong, no.
I have one question regarding this procedure. What are the greater risks when using this type of training? And is it possible to use in normal and hypertense subjects?
So I think Katsu came about for more, I guess you guys, physiotherapy, physical therapy in the States for rehab. So if somebody has damage to their knee, to their anterior cruciate ligament or something, we can restrict blood flow and they use a lot less. So usually we don't, if they have an ACL injury, they don't do anything with that leg until it's rehabilitated. Now, we can strength train that leg at a far less percentage. Maybe we have less atrophy. We might not get hypertrophy, but we keep the strength in the leg. So we don't use it very long, Katsu training, when it first came in. Now I think they're adapting some training for it. You usually don't use it very long. We don't see any long-term effects, damage. We don't see that. As these prescriptions get longer, that might not be so good, vessel-wise.
Mais questões? Ali em cima.
A questão que o professor falou que isso pode gerar um dano, que isso pode gerar um dano no vaso, independe da variabilidade da pressão usada no aparelho?
Ao músculo ou à artéria?
Não, a variabilidade do aparelho, porque você vê que tem alguns estudos que utilizam 60, 80, até 200 milímetros de mercúrio de pressão no vaso, de você fazer a oclusão.
The vessel. Wait, I've only seen one article that looked at vessel damage. Most of them they're still in that developmental stage, in investigating a lot of the benefits of Katsu training to begin with. So the only study looked at, as far as vessel damage downstream, the only one that has shown some increase in just the IL stuff. So inflammation. I haven't seen it.
But has it investigated the amount of pressure?
So if we increase the pressure, do we increase the risk of damage?
Yes. If higher pressures of the equipment lead to higher risks or damage.
So it depends on, so I think it gets back to how long do you leave that cuff on. So if it's on for a long time at a higher pressure, that probably, the arteries run deep, right? Arteries are deep or veins are superficial. So I don't, if the cuff wasn't on very long, I don't think you'd see a lot of damage, even at higher pressures.
Entre pressão e duração. Mais questões? Não havendo mais questões, daria então encerrado este primeiro dia do terceiro Simpósio Internacional de Força e Condição Física, informar que os trabalhos retomam amanhã às 9h30 da manhã, e para os autores dos resumos que serão apresentados em pósteres, que existem informações no site relativamente à sua afixação, mas que esta decorre entre as 8h30 e as 9h30 da manhã. Está bem? Bom dia e até amanhã. Thank you so much.